Good afternoon, everyone. My name is Michael Fan, and I'm one of the PGY1 residents at Earlier Health System located in Chattanooga, Tennessee. I'm here today to talk to you about my project that looked at the effects of an opioid bolus algorithm within the ABCDEF bundle. For this project, neither I nor my co-investigators have any personal or financial disclosures. The reason we're looking into this project is because the ABCDEF bundle focuses on the use of light sedation, as it has shown to decrease time on a ventilator, time to discharge, and mortality rates. However, examining previous literature, the concept of light sedation has only been tested in the realm of sedatives. Currently, there's a paucity of data examining the use of analgesics within the realm of light sedation. At our current facility, analogous sedation is primarily provided through the initiation and titration of a fentanyl infusion. Fentanyl infusions are titrated to a goal RASS score of -2 to 0 and a goal CPOS score of 0 to 2. Our hypothesis is that rapid subsequent titrations of IV fentanyl without the use of a bolus can lead to oversedation and an increase of opioid use. Therefore, a protocol was put in place February of 2019 utilizing bolus doses of fentanyl. The purpose of this project is to determine whether the implementation of a bolus dosing algorithm would decrease total fentanyl use in mechanically ventilated patients within the ICU. As a reminder, this project was conducted at Earlier Health System that serves as the region's Level 1 trauma center, having over 800 acute care beds. This particular project was conducted in a closed medical ICU, having over 24 medical ICU beds. This was an IRB-approved, single-center cohort study. Patients in the pre-protocol group were screened between March of 2018 to September of 2018, and they're compared to patients in the post-protocol group screened between March of 2019 and October of 2019. Patients in the pre-protocol group were screened if one or more doses of fentanyl was administered within the medical ICU. Patients in the post-protocol group were screened if fentanyl was ordered via the ABCDEF bundle order set. For this project and this presentation, currently, the outcomes are presented as descriptive data, and this is due to unforeseeable circumstances around COVID-19 and the turnaround time required for our statistician. However, at the end of this presentation, I will leave my email, so feel free to send me an email, and I'll reply with our final statistical analysis once I have received them from our statistician. Like I mentioned before, the inclusion criteria of this project were patients who received one or more doses of fentanyl and admitted to the medical ICU. Furthermore, patients had to be mechanically intubated for at least 12 hours. Exclusion criteria was intubation greater than 24 hours prior to the admission to the medical ICU, or a GCS score of less than 4, or if patients were put on a continuous infusion of a neuromuscular blocker. The primary objective that we were looking at was total fentanyl use per day while mechanically ventilated. Secondary objectives were time on a fentanyl infusion, medical ICU length of stay, ventilator-free day score, in-hospital mortality, and the percent of RASS and CPOS scores outside of goal range. Here were our baseline demographics. When comparing between the pre-protocol and the post-protocol group, they had a similar age, gender, weight, and Apache 2 score. However, patients in the post-protocol group were more likely to have opioid use or alcohol use prior to arrival. And this is important as those patients have a higher chance of having fentanyl tolerance. Here were the admission diagnoses. When comparing the pre and the post-protocol group, patients in the pre-protocol group had a higher likelihood of a neurological symptom or a malignancy. Patients in the post-protocol group had a higher likelihood of sepsis and or acute respiratory failure. Here were our results. Based on our raw data, there was a median daily decrease of fentanyl in the post-protocol group. This was almost 100 micrograms of fentanyl. While we cannot discern whether this is statistically relevant, we would all like to believe that this is clinically relevant, as for every 3 days a patient was mechanically ventilated, we would have saved 300 micrograms of fentanyl, which equates to almost 2 whole vials of the 150 microgram vials of fentanyl. Here were our secondary outcomes. The patients in the post-protocol group, compared to the patients in the pre-protocol group, had a decrease in duration on a fentanyl infusion. They also had a decrease in medical ICU length of stay. And lastly, they had an increase in ventilator-free day score. This increase in ventilator day-free score was driven by a drastic decrease of in-hospital mortality. However, we would also have to mention that patients in the post-protocol group had a higher percentage of RASS scores outside of goal range. I and my co-investigators would like to attribute this to the nursing education that was provided with the implementation of the protocol. Prior to the protocol at our facility, we knew that we had poor nursing documentation. So to improve patient outcomes, we implemented nursing education on how to accurately assess RAS scores and when to assess RAS scores. As a result, when I was collecting this data, I noticed that not only were more RAS scores documented, but fentanyl titrations were reflective of these RAS scores, indicating that they were most likely accurate. And this brings me to my limitations. Our primary limitation is this lack of documentation in the pre-protocol group. Due to this lack of documentation, it is difficult to discern whether the implementation of this protocol provided tighter analgesic sedation control. Furthermore, since there was no protocol in the pre-protocol group, patients were more likely to be placed on a concurrent sedative infusion. And lastly, we would have to mention that our project did not meet power. To meet an 85% power, we would have to collect 230 patients, and after collecting the 100th patient, we realized that even if we were to extend the interval out to April of 2020, we would still be unlikely to meet this power calculation. In summary, the implementation of an opioid bolus dosing algorithm showed a trend towards a decrease in fentanyl use, a decrease in time spent on a fentanyl infusion, a decrease in mortality, and an increase in ventilator-free days. Furthermore, we would also have to mention that the implementation of an opioid bolus dosing algorithm showed a difference in RAS scores, likely due to a change in documentation. Here are my acknowledgements, and this brings us to our self-assessment question. Does a bolus dosing fentanyl protocol decrease total fentanyl use in mechanically ventilated ICU patients? We have yes or no, and the correct answer would be yes. What we saw was a decrease in median fentanyl use in the post-protocol group. However, at the current moment, we cannot be sure whether that is statistically significant. That concludes my presentation. On the bottom is my email, so feel free to email me any questions or comments. And here is our protocol for you all to examine. Thank you and have a nice day.